Good morning, everyone. I would like to thank Dr. Vijay sir and Yashoda team for this opportunity to present. So my topic is staging laparoscopy and peritoneal cytology in gastric cancer. Is it a must or an optional option? So gastric cancer, as we know, it's an aggressive cancer with an advanced stage of presentation, high incidence of obvious and occult metastasis. So peritoneum, most common sites of metastasis and recurrence. So up to 20% of patients are diagnosed with peritoneal carcinomatosis at the presentation, and they have a bad prognosis with median survival of 6 to 15 months. So imaging in gastric cancer, despite continuous improvement, we depend on CT scans for most of the stagings. They depend on peritoneal characteristics like fat stranding, omental caking, ascites, and nodules, indirect markers. Other modalities being PET-CT and FAPI-PET, MR. So the CT scan for peritoneal carcinomatosis is not adequate, so with high incidence of occult metastasis. So staging laparoscopy with cytology could help in preventing unnecessary laparotomies or staging and then changing the treatment plan. So we detect by staging laparoscopy occult peritoneal implants which are not seen on radiology, and additional peritoneal lavage cytology will detect free intraperitoneal cells which cannot be seen by staging laparoscopy. So there are different guidelines for staging laparoscopy in at different places. So most common is NCCN guidelines, and there are also ESMO guidelines and Japanese Cancer Society which advises staging laparoscopy in Japanese Gastric Cancer Association for advanced gastric cancer and high risk of peritoneal carcinomatosis, whereas almost all resectable cancers except metastatic and early gastric cancers, NCCN advises a staging laparoscopy with peritoneal cytology. Contraindications being obstructive tumors, hemorrhagic tumors or perforative tumors which needs palliative surgery anyway, and history of previous abdominal surgeries. So NCCN recommends almost other than for metastatic and very early gastric cancers, for everyone to undergo a staging laparoscopy with peritoneal cytology. So staging laparoscopy is how it is done. There is a 4-step procedure described in 2018 by Louis et al. The first step is exploration of the anterior abdominal wall on the surface of visceral peritoneum. The ligaments teres falciform ligaments, the right side of anterior abdominal wall. Then the omentum, transverse colon, left colon, and paracolic gutters are generally examined. In the second step, we examine the pelvic peritoneum. In the third step, the small intestine, mesentery from Treats region to the ileocecal valve. And the fourth step, we go on to the stomach and adjacent areas, the lesser curvature, lesser omentum, hepatorenal recess, and other areas. So in addition to staging laparoscopy, peritoneal cytology, in addition to obvious metastasis on laparoscopy, it detects intraperitoneal free cancer cells in the absence of obvious visible mets. This is debatable for early gastric cancers, higher yield for higher stage cancers. So how it is done? So this also, there are multiple ways this is done. One of the procedures is like 500 ml of saline is administered in the peritoneal cavity, 125 ml delivered into the right subphrenic area, right paracolic gutter, left paragolic gutter, and in the epigastrium. Heparin may be used to prevent clogging. Gentle peritoneal agitation may be performed, and after an interval of 3 to 5 minutes, after the lavage, the fluid is aspirated and sent for cytological analysis.